My name is Joe Weidner. I'm going to talk with you about a project that we've implemented at my practice and at the charitable clinic that I'm a part of over the past several years, and I want to see what you guys think of it and how it would work in a charitable organization. We've implemented a mutual support table that is modeled after OpenTable, not the restaurant app, but another 501c3 that has been placing groups of volunteers traditionally around some of the most needy, working with partners such as churches, schools, and others to meet the needs of the homeless population, those coming out of incarceration, those who have teenage pregnant moms, and other groups like that. John Katov, their CEO, was supposed to be here. His flight got canceled because of the storm last night. He was going to book one, but by the time he had to book one that was going to be arriving 2 hours prior to now, it was all booked. So he's not going to be here. You just have me. I'm the better looking one of the two of us. John's the more charismatic one. I'm so sad, though, that you won't kind of feel his energy about this. John founded this organization, OpenTable, 2005. He kind of came to faith late in life. I don't necessarily tell the story, but he's not here, so somebody has to. And he was working at a soup kitchen that his church had, and realized there was a person who just kept coming back again and again. And realizing this person needed others around him. And this person is on their website, is on the OpenTable's website. You can read about Ernie and John and their relationship ever since. But it's those type of interventions that a mutual support table can enable others to do things and meet the goals that they otherwise couldn't meet on their own. And it's that intervention that we applied to a primary care setting, and multiple primary care settings, and are showing some good outcomes that I want to present. I'm a family doc. I've been in family medicine for over 30 years, and in Northeast Maryland, and not always really that intentional about integrating my faith in medicine and my practice, but learning as we go. And so it was here that I came through urging of other friends from CMDA 5 years ago to the CCHF conference that really caught my vision for meeting the needs of others and helped me found a charitable clinic, Clinica Medica Primaria a Rising Sun, that's in the same region that meets the needs right now primarily of the undocumented Latin American community. But it was prior to that time, a few years, that my wife and I were hiking the Appalachian Trail. My wife Kim's over here. She's my helpmate de jour. I don't know. She's sort of our billing manager, and sometimes COVID clinic manager when that need was there. We were hiking the Appalachian Trail, and we're not ones that go carry a tent and stay in it. It's more like Airbnb to inn that we were at. So we were in Boonesboro, Maryland, looking for an Airbnb and booked one there, but our host was late by about 40 minutes meeting us there. She was a volunteer with OpenTable on a project they had to meet the needs of people coming out of incarceration, with the intent to establish a group of volunteers around each person within 48 hours post-incarceration to establish the relationships and the social and relational capital. And it was her, talking with her that night at supper and then breakfast the next morning, and she just couldn't stop talking about this. And I thought, how could this work in family medicine? Now, in family medicine, when we're trying to apply more advanced care measures, including screening for social determinants of health, it's that type of approach that we find important, because we know that social determinants of health needs need to be met, and when they're met, they can show some improvement in patients' health care and as well as their lives, too. I'm building off of a talk I gave a few weeks ago at the Maryland Academy of Family Physicians annual conference, and I just wanted to create some objectives here that you'll learn how that patients' health-related social needs can improve their health outcomes by when those health needs, those social needs are improved on, that their health improves as well. But that the typical screen and refer approach that is common in primary care, screening for social determinants of health and then referring them to services, commonly fails. The mutual support table that Open Tables developed is much more effective at addressing health-related social needs and also improves health outcomes, reduces healthcare utilization and healthcare expenditures. What's most important to me perhaps is that it doesn't require more provider work to do this, but incorporates more of a team-based effort, and that's where I think is important as well. But more importantly to me, to you guys, is to see, is this something that would work in your area, in your clinic, in your setting? Because as followers of Christ, this is what we want to do, is help people where they're at and incorporate measures that can help this. And so that's what I want to learn too. But I'm going to go over some details about our project, but also some of the medical literature that is out there that kind of supports this as well. The model we're talking about that Open Tables developed is called a network table. It's a network of people, volunteers, and we see it as a next step in addressing adverse social determinants of health needs. I'm from Maryland. We're in the northeast corner of Maryland. It's kind of the most rural part of I-95 that goes down the East Coast, kind of right in between Baltimore and Philadelphia. I can see the Orioles or the Phillies within an hour on any given night. So it's handy in that way. But we have people that we take care of, and people who have multiple barriers. And I think of these people, sometimes when I'm seeing them in the clinic, in my exam room, I'm just saying to myself, how many ways can you shoot yourself in the foot? You know, how many ways can you continue to kind of not meet the goals that we've set out, and they just don't seem to improve, and that's despite multiple referrals, perhaps to different social service agencies, multiple identifications of things, but failing to follow through, failing to maintain contact is part of what is common. You may have tried multiple areas, sending them to get food stamps, reaching out and providing transportation, and then providing other educational needs, but you've failed to help Bob, or whatever name of the person that you have in front of you. And so that's where we understand, though, that when these needs are met, that we do have some outcomes that are good. Even in this study, this was from 2016. This was done in 3 different academic centers, I think, that showed that at least when you had a group of care managers, and they primarily reached out through telephone from referrals to people who were in need, there was some improvement in blood pressure control, in lipid control as well. That the lipid levels and the blood pressure control, when you were meeting the needs of, I guess I should have said this was a chronic care management for cardiometabolic disease, that we're trying to meet these needs, that addressing the social needs of people seemed to help improve some health outcomes. This was another example of that. This was done at reaching out to a large integrated system that had multiple sites, about over 7,000 patients who were either low income or had poor education on medical assistance seemed to qualify. And when they did social determinants health screening, they found that 53% of them reported some sort of social needs. However, with the typical approach, that is screening and then referring them on, only about 10% of that 53% found a resource that met that need. However, even with that 10%, those people who found a resource had a 7 to 12% reduction in utilization, primarily emergency room utilization. So that type of health outcome that was found, even though the screen and refer approach only worked for 10% of these people, did have some effect. So the question is how to get this better with the limited resources that we have. This one other study done just within the past couple years went and really interviewed people, providers, social workers, care managers at sites, and just found a lot of limits on the healthcare sector's capacity to resolve unmet social needs. And you guys are saying, tell me about it. Yeah, I understand this. But there's resources that aren't always available. I mean, let alone just referring them. But having lack of availability is key. It's amazing just right now in our county how there's just a housing need. I had the lead of this health department call me and say, do you know any housing that's around? I'm like, I'm not the person to ask. I'm just a family doc. Sometimes there is this level of discrimination too in resource allocation that happens on the part of the staff, on the part of the providers, and on the part of the system in other ways too. This is an administrative burden that can be done. I mean, just when I talk about my office and I talk to my staff about bumping up how we just do screening alone for other types of segments of the population, it seems to needs to be a prolonged discussion about the mechanics of that and who's going to do the handouts and who's going to evaluate that and how much time. So all of these measures do take some work on part of somebody. And at times the alignment of screening isn't always right with patient care, and it isn't always it doesn't always work with and produce that same clinical outcome. There may be some questions that we're screening people that aren't always that important. And I think about this a lot of times. We had a measure, we had an initiative where we were going to do SDOH screening, and still do, and just our Medicare wellness visits. Well, you know what? Most of the people coming in for wellness visits are pretty set for transportation. I mean, most of those screenings were all normal. So, you think how many normal screenings are you going to see just on paper, just for Medicare wellness, and not find many out there. So sometimes we're not always screening the right people because they may not be in front of us, or they may not be the ones filling out the forms that are sent to them. And those are problems that I think we all face. Am I missing any problems? I'm seeing some nodding heads out there too. Anyway, what they found though, and what this next study found, and this was in the New England Journal pretty recently, just in August, was looking at dealing with it in the patient's context. And context is kind of where it gets in the nitty-gritty. What really is going on is kind of the question that kind of starts understanding the context of the patient. The New England Journal article found that this was more central to really providing the care that's needed. And is central to that approach. Now their approach, and they detailed much better than I can how the screen and refer approach failed. Now we saw before where it seemed to work 10% of the time. I mean, they have cited other evidence that somewhere less than 25% of the time did the screen and referral approach work, and it failed 75% of the time. Their process was training providers, physicians and mid-level providers, on where the resources were, and then having the providers make those referrals from the exam room, from the office, from the point of care for the patients there. It wasn't a bad approach, but when you look at the amount of time that it would take, it seems small but would add up. And I wasn't much of a fan, and they admitted this, that it would take more provider training and time to do that. I don't know about you, but time's kind of short. I mean, on my schedule, and I always have a waiting room that's fuller than I am ready to see, or patients that are knocking on the door who want to be new patients when we had been closed for a while until we've reached the capacity. That's where I think the network table model provides that assistance in the context of the patients that we see without any extra provider work, and that's what I want to demonstrate. So Open Tables developed this model. It utilizes the social and relational capital that each of us has in our contact list and our cell phones, through the experience we've had, through the times that we've reached out to people, and when we really didn't know. Now, a lot of us probably haven't been in much need in a way, but I was reflecting on this with somebody who stopped by our exhibit down stairs and thinking about the pandemic and how it was going down, and we were moving outdoors to see patients, and I was thinking, man, I need to have somebody who could I reach out to who could tell me some epidemiologic information? Well, I had somebody who I knew, okay, he's an epidemiologist. I asked him and he said, well, I don't know, but I know this other person from across the country could answer these questions. So we have people like that. I had somebody who, we were using thermometers and pulse oxes outdoors in 30 to 40 degree weather, and I'm thinking, have these ever been used outdoors in 30 degree weather? So I called a friend who just did the research for me. So it's not always that you know somebody who knows that question, but has the resources, has those relationships with others that they could find those resources too. And that's where a group of volunteers who are intentional about this can work well. This can help people kind of in an exponential way too. Typical group of volunteers in this project is about 10 to 12 people. If you think about 10 members of that table, and each person there has 20 connections, those additional 20 members, it can grow exponentially, the amount of resources you and I have, and other people who can meet those needs of others has as well. So it's that type of model that we put together with our practice initially. My family medicine practice is Stone Run Family Medicine, and we were the lead organization in this pilot. We hired a community engagement coordinator. Think of a community health worker, somebody who knows the community resources, somebody who's been trained to work with others to produce outcomes. That person recruits and organizes groups of volunteers. Gathers the referrals from those in need, and in this project it was 1 FQHC, a charitable clinic, and 2 family medicine practices, and then coordinates that volunteers to network and find solutions for each of the individuals' identified primary needs. That we've shown improved outcomes by tapping that community and relational social capital and matching it with healthcare in our setting. And we did this with the support of the state of Maryland. You want me to turn that back? You're going to take a picture of that? Okay. I may be running too fast through this. I don't know. Tell me to slow down if there's any questions too. But the Maryland Department of Health was kind of keen on this, and so they supported this, and that's what helped fund that position for us. We're now self-funding it because we've seen such good health outcomes with it. Those are the 4 practices. Stone Run Family Medicine is a practice that I've been a part of for the past 20 years. 10 years prior to that was with another practice. Clinica Medica Primaria Rising Sun was founded after I was convicted, coming to my first CCHF meeting here. I'll tell you about that story at the end if you want to hear it. They're a charitable clinic that runs as a walk-in clinic on Wednesday evenings and meets the needs of the underserved Latin American population of the area. Neil Lattin's another solo practitioner nearby, and then we have a federally qualified health center that's up the road from us. So it's this regional approach that I think is important, because if you're going to understand the healthcare resources, it helps to have people from that area meet the needs of the practices in that area. And we're recruiting other practices to kind of join us in this too. So I think that's one aspect to this that's important to keep in mind, that I think it works best when you know the network locally, you know the resources locally, you have people locally who can meet with those in need locally. So what does this look like to a patient? And this is maybe a little bit too detailed. I'm trying to revise this slide sometime. But we screen for SDOH kind of routinely at Stone Run and identify some patients who have needs that then we refer to the community engagement coordinator. After we have them meet with our care manager, many times our care managers will already understand what some of the needs are. What's important at our office too is that the staff get involved with this. So, we've had at times referrals from the billing department because there's a financial need identified, or the front desk, which I think in my practice is a great sense of intel. I mean, they can tell me what's going on in the community. Oh, this person just got out of jail, and this one, I mean, so they're sometimes identifying somebody with a transportation need that then turns into something else. But our process is to send them all to the care manager there. Now, I don't know how your clinics work. I mean, we meet every morning in a morning huddle. Providers, clinical staff, and clerical staff. Anybody except for 2 employees, just to meet the patients as they're coming in. So we go through this every morning as part of it. We look at who's coming into the hospital and gone out of the hospital, who have other transition to care visits. And then we identify anybody you think would be worthy of open tables. So keeping that in mind on a regular basis, I think, helps from a practice-wide standpoint. The Clinica, though, serves as a walk-in clinic, and it gets a little crazy. We don't do the greatest social determinants of health screening, and everybody seems to have some types of needs too. So what we've done is primarily do our screening and intake at a food distribution that we've partnered with the Maryland Food Bank. They bring a mobile food unit in our parking lot of the Clinica and the practice monthly, and then we have people go around with clipboards and ask people to fill out needs and identify patients that way. Dr. Latin just refers patients directly. He has like 2 employees, and he just walks over to or calls the community engagement coordinator and refers people directly. The FQHC up the road hasn't really educated much of the staff about this, but just the care managers alone. Those care managers are the only ones who are identifying people in that FQHC, and they refer them on. So then the community engagement coordinator, who's working part-time, she's about 20 hours a week, meets with the patient, who in this model becomes a friend. I mean, how you want to term this person's name, but the person in need, and they determine what's the primary support need. And that's an important concept that's new to a family physician, because many times it seems like it's a transportation need, but it's not a transportation need. It's somebody to stay with the dog at home so they can get to the office, or somebody can't get their medicine because of another bill that they have to meet, or because their lawn they can't get mowed. And sometimes it's simpler things like that, but it's not always apparent to me what the primary support need. And that's where this model has helped train a community engagement coordinator to identify what's really going on. It's kind of like the big question, I think, is you end up asking. This community engagement coordinator then brings that need to the network table and volunteers and assigns that to usually 2 people, maybe 3, who meet with the patient who's now a friend of the table, and who finds a solution to that need, that person. Now, the last time I presented this, somebody asked, how long does it take to meet this need? Sometimes you can make it a few hours. If I think we had somebody who just needed an air purifier last week. Okay, well, maybe if we can find one of those. Sometimes it's like weeks, that you're really trying to sort out what the need is. Sometimes it's much more involved. We had about 12 families flooded out of their trailers, primarily from the Clinica, several years ago. And so one of their families, that may be later in this talk, but sometimes it's just an ongoing type of need. Yeah, too. This is more the referral process, more in a graphic type of set. That's Mary up there, too. So the Clinic and Stone Run, and actually, Latin using the Maryland Food Bank to do SDOH screenings as well. The other FQHC, West Cecil Healthcare, has the food bank come in. They don't do the screenings. We're trying to work them along and try to see if they could encourage them. Because it dawned on me, if you have people come for food insecurity, there's a good chance they have something else going on. Why not screen them then for those other types of needs that may be keeping them? Let me go on and tell you how we do this. This is just a picture of what our food distribution looks like on any given day, and this happened to be a sunny one, which was fortunate. They come to Stone Run Family Medicine once a month. We're able to follow up with people that we screen, and many times apply the open tables, network table model with those in need. We've had plenty of individuals that have had some outcomes. I was telling you about that. There's one family that we had the volunteers find another place for this family to live and negotiated the rent for them to help them with the contracting, help them find bedding and mattresses and other supplies. Many times we have durable medical equipment needs that just aren't being met or uncommonly being met, and there's some services that we've connected people with. But it's not just connecting, it's like getting it there, getting it set up, making sure the patient uses it, and that relationship that develops in an ongoing way can be helpful too. There's others that have just needed connectedness too, where you find there's this loneliness and these barriers that build up too that the volunteers have worked with. And then finding other health resources too. The volunteers have called out to other providers they've noted. Dental care has been, some success with that. We don't have a great system for providing dental care like a lot of you may have in your charitable clinics, but in our area that we've been able to find dental care and negotiate those rates down with some people. Sometimes it's building a ramp on a house. Somebody has a condition where they need that to get out, and volunteers helped connect people who could build the ramp or reached out to other handyman that we've had. An elderly couple were going to get fined if they didn't clean up their property. Volunteers went out and raked the leaves and mulched and weeded the property so that they could stay in the place where they were at. A friend who was disabled had a deck that was falling apart and dangerous and needed it fixed, and the volunteers from the network table were able to connect her with an agency that fixed her deck and deck stairs. So those are a number of the needs that we've had, and they can really vary. How do you get volunteers to do this? It's kind of a bit of what I was asking ourselves after a couple years. How did we get the volunteers that we looked at that? One of the first persons I had was a friend of mine, a prayer group I meet with, a bunch of guys on 6 a.m. every Monday morning before we get off to work. He was pretty interested in it. He was a retired school counselor. He had been a volunteer for a couple of years. We asked people who are volunteers to commit to a year. Volunteers shouldn't be forever. I think John lasted about 2.5 years, and before he found reason to do other things. Sometimes people call the national organization, Open Table is a national organization. They have projects that are all over the country, different areas, and I can tell you more about other projects they have. But sometimes they'll get somebody calling, looking to do some project. He said, well, why don't you be a part of this Open Table we got nearby, this network table, and you can see how it works. Sometimes there's a patient in front of me who's like recently retired. I've had a couple guys who are like bored, they're retired, they've been successful, they got time on their hands. It's a great fit, I think, if they have the heart for this type of thing. One of the interpreters at our clinica is one of the volunteers. A lot of times mental health counselors and people in education seem to be more likely to be on. When I look at who's been there, people have education backgrounds who've been in social work or guidance counseling are common with this. We've had other staff members, other friends of a friend be part of this. The community engagement coordinator will go talk with volunteer organizations like the Rotary Club and will engage some people that way. I have one guy who, when he retired as a roofer, he said, Joe, just tell me what, if you have anybody who has any needs, just I can fix it, I'll take a look at it. So we've called on him a lot of times, and he was a volunteer for a while, just serving on this table too. He's been awfully handy because he's a handyman, I guess, yeah. But building ramps and assessing somebody's roofing need, and I was doing a house call on this one gentleman and then stepping through his floor, and he replaced that part of the floor that went to the bathroom because he needed to use that area. We have a patient family advocacy council, part of our practice, where patients and family members come together every 3 months and just answer questions we have and offer suggestions for how we practice. And one of them is our town commissioner who said, I'll put a flyer in our water bill. And we saw the flyer like for a couple months going. And we've gotten some volunteers that way. A board member of the Clinica volunteered. So there's a lot of different ways we've found where you can get volunteers. And I think it'd be something, I know some charitable clinics seem to have a lot of volunteers, a good roster of people. And if there's somebody out there who's thinking, how could I use my volunteers? This is really a good approach, I think, to engage other volunteers who want to be out to help people. This is a slide that kind of details the volume of what we're seeing, the practice volumes that are part of this project. We started this with our first patient from Stone Run at the end of 2021, and then have sequentially added practices as we went along. The number completed at the end, I haven't updated it. We're at about 170 people have completed the network table intervention there. But here are the outcomes that we've shown. When you do a promise survey, which is a survey of the patient before and after the intervention, we survey them right at the intake when the community engagement coordinator meets with them. And then about a month or two afterwards, you see that 52% of them have improvement in their medical health status, 49% in their mental health status. For the practices, not the walk-in clinic, but the other practices, we've been able to capture no-show rate and visit cancellation rate. And we showed that out of 46% of the individuals who had the network table applied, we've shown improvement in that no-show cancellation rate. We looked at 3 years prior and looked at that rate and then annualized it according to the amount of time that we had when we looked at this last at the end of this past December. The ER utilization rate we have good data on from the state of Maryland. They have a health information exchange that requires every hospital to submit data, including ER utilization and inpatient utilization. So even the undocumented Latin Americans in the Clinico, we were able to obtain this measurement. We showed that before and after for the individuals have had 86% of them had an improvement in their ER visit utilization rate. 3 years prior, and then subsequently after that. And that after varies according to when they were enrolled in open table. And then the inpatient rate was similarly improved. Not a whole lot, not as much as the ER utilization rate, but 79% of individuals had a lower inpatient admission rate. Now, let me give you two caveats about the ER and the inpatient utilization. We didn't count people who didn't go into the ER at all or the inpatient at all. These are all high utilizers who had at least one per year of ER utilization or inpatient rate. Okay. The state of Maryland also has for Medicare patients, because we're in a separate Medicare pilot called the Maryland Primary Care Program, good health data on expenditures. Like we can look at how much expenditures are on the Medicare patients. And for the Medicare patients, we showed that 76% of those individuals enrolled in here had reduced healthcare expenditures. And when you look at that, that's a 34% reduction in total healthcare expenditures for Medicare. So that's caught some people's attention, in a way, and perhaps not your population if you're not, if you're dealing with people who don't have insurance anyway. But I think all these measures kind of go hand in hand, that this has some goodness in it and it helps with improving health as well as utilization of healthcare in ways that we'd all like to see and strive to do to keep people out of the emergency room and to keep people healthy. We did compare this to a placebo group, at least the Medicare patients we did. We tried to stratify them to have a similar hierarchical category code. The HCC code. I hate trying to say the word hierarchical. Condition category. I don't know about you, but that's why everybody says an HCC code. So an HCC code, for you that may not be familiar with it, it's applied to each patient, and there's a code for each diagnosis. And it varies according to that. There's a cumulative effect, but it gives you an idea of how likely is that person to have healthcare costs in the next year. I think that's how it was originally developed, is to look at healthcare costs as a predictor of estimated future healthcare costs for any given individual according to their diagnoses and other factors. So we took 25 of the we looked at our whole Medicare population and said, what's their average HCC code? And then we took that number and lined up all the patients we have in their HCC code and took the 25 that are closest to that number. So we tried to match it kind of in a similar cohorts. And then we compared that data to the kind of a before and after. The average date that we had an intervention and looked at this, and there's a bit of a data lag because Medicare doesn't submit all this data in a timely way. But what we found in a similarly matched cohort was that there was an 8% increase in the total healthcare expenditures during that same time period as those patients in a who had the mutual support table that network table provided had the 34% reduction in healthcare costs. Okay. Now I throw in here just their ages too. The ages we didn't try to match. The ADI is the area of deprivation index that kind of looks at the census tract and identifies what other factors in that geographic location could affect, or the social aspects that could affect their health too. But that's the data we're continuing to examine, and just only recently, like this past 6 months, look at that placebo group. So we've shown some good outcomes with this. We're continuing to work with this. And for those of you who bill Medicare out there, there's actually codes out there that you can get paid for that kind of support this now, just as of January 1st. They have this code called Community Health Integration Services. Now, it has to be performed by a community health worker or staff, they say. So they're not specific. It doesn't have to be somebody trained as a community health worker. But when you look at this role of a person who coordinates volunteers and captures patients there, that we call a community engagement coordinator, it's very, very similar. It's a type of skill set that I think is very similar. But this person, this coding, this payment that Medicare will pay, that CMS will pay, is for this person to address the SDOH needs that are barriers to diagnosis and treatment. I'm thinking, I could have wrote this for you, this code. When I saw this description come out, this is exactly what we're doing. This is the fee schedule for the part of Maryland we're at, which CMS says the rest of Maryland, not the DC suburbs, not Baltimore, but everybody else. And we're getting payment for these codes right now, and this is just the time spent. So for the first 60 minutes that the community engagement coordinator or other staff member who spends doing this gets this amount of money, and for each additional 30 minutes as well. Somebody asked me, do volunteer time, can you bill for that? I'm like, I haven't asked the question yet. It's CMS. I'm not sure that fits with their definition. But for somebody who's paid like a community engagement coordinator, community health worker in this role to coordinate this, I think this works well. There is also payment for, yes?
I can tell that. Is this for telephonic calling?
It's not specific to telephonic or intervention. It can include the time on the telephone, I'm pretty sure. Yeah. Any other questions about that? There's also payment that Medicare will make now for doing a SDOH assessment. Now, when they describe how to do that assessment, they indicate to use a risk assessment tools, and they mention ones that I think are common screening tools. But then when they talk about, then they say, well, we're not paying for screening. We're paying for those who you identify or think have an SDOH need, and you're assessing them. I still have some more questions than answers about this code set, but I think when we identify somebody with our SDOH screening, and then we go through the initial assessment, I think this is a code that would apply for that person who you've identified of having a need. Anybody billing for these codes out there? No, okay. I mean, they're brand new, and I was just curious if anybody else had any experience with that. So we'd like to see how this would replicate in different settings and what it would take. Now, I have there what we were doing probably a year ago, which is a half-time community engagement coordinator for 8,000 to 10,000 patients. And I got to change this slide because I think a part-time person could probably handle practices up to 16, even 20,000 patients, just the volume of SDOH needs. I think it depends on your practice in a way. If you have a charitable clinic where everybody's undocumented and they have multiple needs, you're going to have a busier care coordinator than you are in a for-profit practice, perhaps. It'll take some understanding and education on the part of the office regarding the model, and it really engage staff to recruit patients. I think is very important and has been very helpful in this. because it takes a team, but a team to identify those people. A couple hours training, at least of providers and staff, and then an identification process, whether that comes through care managers, whether that's directly from providers, whether that's from a screening approach at a food outreach or some other process. And then materials that are used to help educate people, to engage people, to capture volunteers, to capture potential patients. Those would be the items that I think it would take for a practice, a clinic to implement this. So, what I presented would look like we've shown better health outcomes in people, at least by their self-assessment, in medical and mental health, less health utilization of healthcare services, and overall better living with some improvement in the healthcare expenditures that you could quantify in patients in a per member per month way for those who are part of models that look at this. Our patients' health-related social needs can be effectively met with a network table, and that enrollment improves health outcomes, reduces healthcare expenditures, utilization, all without more work on my part, except for giving talks on this. What questions or thoughts do you have? Go ahead.
Yeah, thank you for this model.
Sure.
So in North Carolina, we have a model called NCCare 360, which is a platform, electronic platform of referrals.
Right.
So once you do the evaluation, you see what the patient need is. And this platform, you can say, needs health, needs food, and then it's put out into the community to pick up those referrals. I'm really interested in this idea because it seems like this is very relational.
Yes.
People meeting with an individual and then walking with them to meet the need.
And those are my words too. I mean, I was going to use the word walking beside them. Yeah.
So I'm really curious about that. How this volunteer group to meet with somebody. That's a layer of complexity, but it's really wonderful, in that you're creating this. So can you talk just a little bit about that relational component of people's experience in the community, meeting with a patient in need, and what that actually looks like?
I'm thinking I wish John was here. He would really want to talk about that, the CEO of Open Table. I think it does transform people. And I think the other question is, well, what's so mutual about this mutual support table? How do these volunteers who are part of it, are they, they seem like they're meeting the needs of these people, but it's that relationship over time that really helps anybody who's volunteering and helping the need to kind of develop that relationship too. I mean, we have a person who, I mentioned before that I did the house call, and I put my foot through his floor, and we brought out somebody to fix that floor. But then he had some ongoing needs that you could find. He ran out of money for enough food towards the end of each month, and the Open Table recruited about 7 different businesses to donate food to him on a monthly basis there. But then there's some ongoing needs that he's had 2 that are community engagement coordinators develop kind of more of a relationship. And as we go on, we're understanding kind of some of the dynamics that are keeping him from being healthy. I can go into more details, but I guess, is that answering your question, I guess?
Yeah, I guess, so have you seen that, so you say that you identify the primary
support need. And that takes a bit of understanding on the part of the community engagement coordinator to really ask a number of questions. And it's not...
Then you connect them to a team of support to help them. Does that team then, when they close that initial primary support need, they say, oh wait, you've got a new primary support need, let's go back to the table and maybe meet a new group of people? Or does this team then just become that person's support, over forever maybe,
It can happen in one way, and it almost depends on the need. Now, sometimes people have a very specific need, and once you meet that need, there's not an ongoing need. some people seem to have more and more ongoing needs, and that's where I think that relationship helps with that. I don't know that it's a new set of volunteers. It's still typically the same group of people, and most of the time they pull the same individuals who are volunteers to help meet that need because that relationship has started then. So I think what we're finding is out of 170 so, and I'm guessing at these numbers, but it's something like about 20 or 30 people come back again and say, and maybe even call the community engagement coordinator directly. They haven't been identified with an SDOH screening or other area, and they're saying, hey, I've got this now. And so that does happen. And I think with some of the most needy, they're the people who need the closest walk beside them of others there. And as those relationships develop, that can be really close, where there's really friendships that develop from the volunteers to those in need. With this model, we haven't seen that happen as much as in other models that Open Table has had, where there's people who are just daily in contact with those people who have just nobody else. They've burned every bridge, and they just need to kind of have ongoing people walk beside them. But we're entering a phase in this project where we're looking at that with a few individuals, where I think that's going to be a much more of a, you can be a volunteer and here's your person, and really gain some relationship with that one individual too. So I'm trying to recall what John told me, a lot of what he's thinking about this on a national scale and how they've done this with different models, but you've built that. And I think a lot of other organizations have this at some level. I even remember when I was in training hearing about family docs who when they opened up their office in the morning, their staff would call a few people because they knew this person was like borderline dementia. Did you wake up? Did you take your medicines? They would kind of be that person, like a staff member would do that. But you think about primary care in general and how dysfunctional it is in meeting these types of needs and having that person. That's where this model kind of starts to address that. Go ahead, Shakina. Shekinah, I'm sorry.
For your network table, are each of the patients assigned to the network and they're kept up with the patient for like a certain amount of time, or how does it work as far as like the actual care for the patient too on the medical side versus the social determinants?
Well, the care on the medical side continues to happen according to what the providers and the patient, dictate. The amount of time they spend with the network table depends kind of on their needs sometimes. If they're assigned volunteers, it may take some time. So the length of time that they're part of the network table almost depends on how much their needs are met.
Okay. And so the network table, their job is just to reach out to the community to find the resource, right?
Well, not really. In this model, the providers and the practices have identified people in needs. So it's not reaching out to the community in a way, but almost integrated within a medical type of practice that identifies, that does SDOH screening and identifies those needs. Instead of just referring them to services, it has the network table work with them in these services. Yeah. All right. Okay. You back there? Yes.
Yeah, as I listen to this, so my experience is more with international community health and development, but and specifically in a context where we're trying to mobilize the church to engage with their non-believing neighbors. So is there linkages within this model with what I would see as some could be diaconate type tasks within a church? Like this just seems super perfect. I don't know, not to use fancy language, but to build partnerships between medical practices and churches who could have these trained communicate. Has that happened to partner with churches?
It hasn't officially. I mean, now Open Table has partnered with churches and they've been the lead in this, but not with a medical practice, but that's where we're going. I presented it to our congregation that has really identified that we haven't done much local outreach or as much as we've had to. Now, part of the rub is, though, I don't want to take away volunteers who, while the church is struggling for volunteers too, but still, I mean, if you're looking for ways to have your congregation reach out to that, we've had another, well, that's a separate issue. We have other churches that approach the Clinica that said, hey, we don't want to be part of that. And so our role is like, well, how can volunteers who don't know Spanish, for one, because everybody needs to know Spanish, work with the work with the Clinica. Well, part of it may be a volunteer on the network table for the Clinica. So yeah, I think that's a good point. That's something that we haven't fully explored. Yeah. Yes, 5 minutes. Oh, that's what your 5 was. Yeah. The student's telling me I got 5 minutes. Well, the question. Go ahead.
Sorry,
Yeah.
yeah.
Hi.
Just a kind of
You.
off-related question, but I often find it's very difficult to recruit volunteers, especially in my context. I'm thinking, who could be volunteers? They're like people with a lot of time, so that usually ends up being like high school or college students that they can pick up a phone call and they can read it. That's about as good as it gets. But to kind of implement this kind of model, it implies that there are people who have professions that are able to contribute further into their society. How do you go about trying to recruit people like that without completely guilting them into donating their time and donating their resources?
Yeah, I think you just spread the word. I think Open Table as an organization probably has a better answer than mine to this, because they've had years and years of engaging volunteers in this, and that's part of the process that they train a community engagement coordinator to do that. I think it's getting people interested in it. I mean, that's how I got interested in it. It was a volunteer who was really interested and was really like engaged in this process. So now I'm not volunteering though, but I think that's how somebody else may catch the fire of this. I don't think I have a better answer for you with that. There's something there, but I think it's people that and I think for me, when I'm sitting with somebody who I think you'd be a great volunteer for that, I'll give them the card or a handout. I got to be on my game and think of it, because I'm in the exam room trying to think of so many other things. Yeah. Did you have a question? Yes.
We are looking to bring in CHWs into our practice.
Yeah.
Have it in the budget to start later this year.
Okay.
So I know you mentioned they're kind of like that, but from my understanding of CHWs, there's a lot of education, and they get trained in how to educate. How does that differ from what you were showing? Like, it seems like they're putting pieces together of like actual, let's practical things, let's walk with you and do those practical things. CHWs do that, but they also do the education. Are you seeing that happen, or is that not with this? Or?
A CHW would be an ideal candidate to be a community engagement coordinator and run this. Yeah, if you have a CHW who needs something to do, or you're trying to find a way to engage volunteers to help patient outcomes, that's where they would be an ideal person to run a network table for your organization if it's a charitable clinic, and help meet those needs of the patients that you have, those with the highest barriers to care, by engaging the group of volunteers, by doing the training on volunteers and understanding that network of community resources out there. Yeah. I want your name and number. Yeah. Any other questions out there? Thanks so much. My email's there. Email me anytime. All right. Thank you.